Hello and welcome to the lecture on diseases of the endocardium. We've discussed diseases of the pericardium and myocardium. Now let's complete our series on diseases of the heart wall by discussing diseases of the innermost layer of the heart wall, the endocardium. This image provides an excellent summary of where our focus will be. The endocardium primarily involves the heart valves and associated structures. Take some time to review this relevant anatomy. In the review lecture at the beginning of the semester, we introduced you to the normal heart sounds. The S1 is the lub of the lub-dub that you hear with the normal S1 and S2. It represents systole. S1 represents closure of the atrioventricular valves and opening of the semilunar valves. The atrioventricular valves include the mitral and tricuspid valve, and the semilunar valves include the aortic and pulmonic valve. A good way to remember how to categorize these is to remember that the atrioventricular valves communicate between the atria and ventricles. Remembering this will allow you to recall that the semilunar valves lead out of the heart. In summary, during S1, the semilunar valves open. Blood is flowing out of the right heart into the pulmonary circulation and out of the left heart into the systemic circulation. The second heart sound is the dub in the normal lub-dub. S2 represents diastole, and during this time the semilunar valves close while the atrioventricular valves open. The net effect of this is movement of blood from the atria to the ventricles. I thought I would go ahead and include the S3 and S4 heart sounds, since the majority of our discussion in terms of identifying endocardial disease is through accurate recognition of heart sounds. The S3 is also known as the ventricular gallop, and it occurs after S2 when the mitral valve opens, allowing for passive filling of the left ventricle. An S3 is an indication that there's a large amount of blood striking a compliant left ventricle. In other words, the patient's in an increased fluid state, as you would see with pregnancy or heart failure. The S4, on the other hand, is a low-frequency gallop sound that results from a forceful atrial contraction during presystole. An S4 indicates ejection of blood into a non-compliant left ventricle. This means that the blood is moving into a stiff, rigid, or non-compliant ventricle, as you would see in a myocardial infarction, left ventricular hypertrophy, or chronic hypertension. This image gives you an idea of how the heart sounds will line up with the EKG. You can imagine how S4 would occur over the area where you would expect atrial contraction, where you normally wouldn't hear a sound. The S1 reflects ventricular depolarization and systole. The S2 reflects ventricular repolarization and filling during diastole. And the S3 reflects a fluid overload state, making an additional sound as the fluid approaches the ventricle in the next contraction. Now let's discuss heart murmurs. Murmurs are an acoustical phenomenon produced by turbulent blood flow. The chance that flow will be turbulent in a situation is dependent upon Reynolds number. You don't have to memorize this equation. I'm just using it to kind of show you how these sounds are produced. So most commonly, these sounds are produced by changes in velocity and viscosity of blood. Increased velocity of blood can occur through morphologically normal structures or through narrowed structures. And velocity refers to the thickness versus the thinness of blood. Here's a table breaking down the etiology of murmurs as it relates to Reynolds number. Decreased blood viscosity can occur with anemia. A decreased diameter of vessels, valves, or orifice can occur in valvular stenosis, coarctation of the aorta, or ventricular septal defects. Increased velocity of blood through normal structures can occur in hyperdynamic states such as sepsis or hyperthyroidism. Regurgitation across an incompetent valve can occur in valvular regurgitation. There are several characteristics of murmurs that will help you identify what the underlying pathology is. This can be organized into a quick mnemonic, LPQRSTI. For the purposes of clarity, I've reorganized the characteristics. Let's start by looking at pitch. Pitch can be related to either high pressure gradients, such as with a ventricular septal defect, producing a high pitch, a large volume of blood flow across a low pressure gradient, as with mitral stenosis, producing a low-pitched sound, or a high-pressure gradient with a large volume flow, such as with aortic stenosis. In this case, you'll hear simultaneous high and low pitches, referred to as harsh. There are a variety of qualitative descriptions of murmurs. I've listed those here in a chart. Mitral regurgitation is often described as a blowing or musical sound. Mitral stenosis is often described with a rumbling sound. Aortic stenosis is often harsh. Aortic regurgitation is often blowing. A Stills murmur is often musical or vibratory. And patent ductus arteriosus is often described as machine-like. Intensity refers to how loud the volume is. This depends on velocity, ambient noise, and experience. It's often described using a grading system on a scale of 1 to 6. A grade 1 murmur is barely audible. A grade 2 murmur is soft but heard easily. A grade 3 murmur is loud. A grade 4 murmur is a loud murmur with an associated thrill. A grade 5 murmur can be heard with partial stethoscope contact with the chest wall. And a grade 6 murmur is audible without a stethoscope. The best differentiation for you to keep in mind is the difference between a grade 3 and a grade 4 murmur. Timing refers to when the heart sound occurs in relation to the cardiac cycle. Does it occur in systole, diastole, or both? You can determine whether a sound is occurring in systole versus diastole by feeling for the carotid pulsation while simultaneously auscultating the sound. If the carotid pulsation occurs just after the sound, then the sound is occurring in systole. I've provided a table showing how the valvulopathies fall into the category of systolic or diastolic. The shape describes how murmur intensity changes from onset to completion. There are 3 different types. The first is crescendo-decrescendo. The second is decrescendo. And the third is uniform or holosystolic. A crescendo-decrescendo murmur becomes loud and then progressively quieter. A decrescendo murmur begins loud and then progressively becomes quieter. In a uniform murmur, the sound is relatively constant. Here is an excellent way to remember valve location. In this memory jogger, remember all people enjoy Time magazine. Another variation of this memory jogger is ape to man. The aortic valve is located at the right second intercostal space, right sternal border. The pulmonic valve is located at the left second intercostal space on the left sternal border. Erb's point is the best place to listen for the S1 and S2, and it's at the left third intercostal space. The tricuspid valve is located at the lower left sternal border in the fifth intercostal space. And the mitral valve is located at the left fifth intercostal space, mid-clavicular line. Radiation refers to the location where murmurs seem to travel to. It describes other locations where the murmur is audible despite not being directly over the heart. Murmurs generally radiate in the same direction as the turbulent blood is flowing. There are two different maneuvers that will help you identify a murmur. Clenching your fist will increase afterload. This can distinguish mitral regurgitation, where you'll see an increase in intensity, and aortic stenosis, where you'll see a decrease or no change in intensity. This also may help bring out the murmur of aortic regurgitation. Squatting or the supine position will increase venous return. This results in an increase in stroke volume. This may help distinguish aortic stenosis, where you'll hear an increase in intensity, or hypertrophic obstructive cardiomyopathy, where you'll hear a decrease in intensity. Here's a summary of the characteristics of heart murmurs. In terms of documentation, you want to include as many of the characteristics as you've identified in the heart murmur. For example, a harsh grade 3 out of 6 systolic crescendo-decrescendo murmur, heard best at the second intercostal space, right sternal border, that radiates to the right side of the neck and is diminished by a clenched fist and louder in the supine position. If you look back, you'll notice that this best describes aortic stenosis. Now let's discuss the valvulopathies producing these murmurs. With valvulopathy, it all boils down to the direction of blood flow. Alterations in the direction of blood flow results in the manifestations seen in each valvular disorder. Let's start with aortic stenosis. Aortic stenosis involves stiffening or narrowing of the aortic valve. This comes from either fusion or fibrosis of the cusps or commissures. It produces a systolic problem. As you could imagine, when the left ventricular contracts, blood can't flow out of the aortic valve and through the aorta into the system. You'll see higher left ventricular diastolic pressure because the ventricle's unable to eject the blood out and through the aortic valve. In order to stretch the aortic valve enough, you have to have a higher preload. This increases oxygen demand and decreases delivery. Aortic stenosis has a variety of etiologies. Most commonly, in approximately 80% of patients, it comes from calcification of the valves. This can be secondary to smoking, hypertension, diabetes, or hyperlipidemia. It can also be congenital, with coarctation of the aorta or Turner's syndrome. You can also see it with rheumatic heart disease, connective tissue disease, radiation, or chronic kidney disease associated with abnormal calcium homeostasis. In order to visualize the symptoms of aortic stenosis, think about the aorta. You're going to have decreased blood flow through the first branch, or the coronary arteries. You'll have decreased blood flow through the right and left carotid arteries, as well as the left subclavian artery. This poor blood flow produces the cardinal signs of aortic stenosis: chest pain, syncope, exertional dyspnea, and paresthesias to the upper extremities. In aortic stenosis, you'll hear a harsh crescendo-decrescendo systolic murmur. You may feel an exaggerated point of maximal impulse, which should be at the fifth intercostal space, left midclavicular line. You can also see pulsus tardus, which is a weak or late pulse compared with normal expectancy. Medical management for these patients includes digoxin, ACE inhibitors, and diuretics, primarily the treatment of heart failure symptoms. In mitral stenosis, you see fusion of the commissures or chordae, resulting in impedance to blood flow during diastole. This results in an inability to fill the left ventricle, resulting in a backup of fluid into the pulmonary bed. In 95% of cases, this comes from rheumatic heart disease. You could also see it, though, in congenital diseases, systemic lupus erythematosus, mitral annular calcification due to aging, or or amyloidosis. Mitral stenosis is manifested by dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and symptoms of heart failure. You can also see atrial fibrillation in these cases. And that's primarily because if you have a stiffened mitral valve, blood's going to back up into the right atrium. When this occurs, it disrupts the normal communication between the sinoatrial node and the atrioventricular node. And finally, in these cases, you'll hear a low-pitched diastolic murmur. Aortic regurgitation is a problem with diastole where blood flow is no longer unidirectional, resulting in left ventricular hypertrophy, dilation, and failure. It's manifested by dyspnea, especially on exertion, chest pain, symptoms of heart failure, dizziness, and palpitations. On the physical exam, you'll hear a high-pitched and blowing diastolic murmur. You may feel a diastolic thrill, and the point of maximal impulse may be shifted to the left. Some additional findings include the water hammer pulse or Corrigan's sign, which kind of resembles a rapid upstroke and then a quick collapse when you're feeling the pulse. You may also see de Musset's sign, which is a head bob. Another finding may be a Quicken's pulse, where there's alternating flushing and pallor of the nail beds. And finally, you may see Traubé's sign, which is a pistol shot sound over the femoral artery. Aortic regurgitation can occur with a congenital bicuspid aortic valve, rheumatic heart disease, Marfan or another connective tissue disease, syphilis, which results in aortitis, and potentially hypertension. You can also see it in aortic root dissection or vegetation. Medical management includes diuretics, vasodilators, such as hydralazine, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers. Mitral regurgitation involves a failure of the leaflets to close, resulting in a backflow into the atrium during systole. This results in reduced stroke volume and left atrial dilation. It's manifested by dyspnea, orthopnea, and paroxysmal nocturnal dyspnea, dysphagia due to an enlarged left atrium, a high-pitched holosystolic murmur, an exaggerated point of maximal impulse, and you may also see preventricular contractions and supraventricular tachycardia. Mitral regurgitation can be seen when there's a problem with any portion of the valve due to mechanical, traumatic, infectious, degenerative, congenital, or metabolic causes. Acutely, mitral regurgitation can occur with infective endocarditis, ischemic papillary muscle dysfunction or rupture, acute rheumatic fever, or acute dilation of the left ventricle due to myocarditis or ischemia. Chronically, it can be due to myxomatous degeneration of the leaflets or chordae tendineae, mitral valve prolapse, or mitral annular enlargement. I will briefly describe some key points about tricuspid and pulmonic valvulopathies, as these conditions are not quite as common or problematic. Tricuspid regurgitation can result in right heart failure as well as a right bundle branch block. It's manifested by a high-pitched blowing systolic murmur. Tricuspid stenosis may coexist with mitral stenosis and produces a low-pitched diastolic murmur. It's manifested primarily by fatigue and poor exercise tolerance, and it can, in rare cases, lead to right heart failure. Pulmonic stenosis can increase the workload on the left ventricle. It's rarely secondary to cancer. Pulmonic stenosis is manifested by a harsh systolic murmur, dyspnea on exertion, and symptoms of right heart failure. Pulmonic regurgitation can increase workload on the right ventricle and is often manifested by a high-pitched diastolic murmur and symptoms of right-sided heart failure. Now let's discuss the diagnosis of valvulopathies. The diagnosis involves identification of a murmur, patient presentation, and an echocardiogram. Often a valvulopathy may look like a myocardial infarction or a cerebrovascular accident. So in addition to the echocardiogram, clinicians will often order tests to rule out a myocardial infarction or a cerebrovascular accident. For a stroke, testing often includes a CT of the head without contrast, an MRI and MRA of the head and neck, and a carotid ultrasound. For a myocardial infarction, the workup will include an EKG, a troponin trend, and a nuclear medicine stress test. The echocardiogram will show movement of the valves as well as the blood flow. Now let's discuss valvulopathy management. In addition to some of the medical management points I discussed with individual valvulopathies, there are two categories of surgical management: valvular repairs and valvular replacement. There are some key risks associated with valvular repairs and replacements that you should be aware of: thromboembolism, anticoagulation hemorrhage, prosthetic valve endocarditis, leaks, and prosthetic failure. A commissurotomy is also referred to as a valvulotomy, and it consists of making one or more incisions at the edges of the commissure formed between 2 or 3 valves. This is done in order to relieve constriction, such as occurs in valvular stenosis. An annuloplasty involves the implantation of a device surrounding the valve called an annuloplasty ring, which pulls the leaflets together to facilitate coaptation and aids in the reestablishment of valve function. A chordoplasty involves the repair of the chordae tendineae. A valvuloplasty involves the widening of a stenotic valve using a balloon catheter inside the valve. This often helps with valvular calcification. If repair is not an option, then replacement is indicated. This image shows a ball and cage prosthetic. Here is a visual example of a tilting disc, often referred to as a Bjork-Schiley. Finally, here's an image of a porcine valve. Transcatheter valve replacement is a newer technique for placing a prosthetic that involves the introduction of a valve prosthetic through the use of a catheter. This newer technique saves the patient from having to undergo open heart surgery. When a patient undergoes a valve replacement, it's important to encourage adherence with an anticoagulant regimen. For the patient receiving a mechanical valve, warfarin must be taken with a target INR of 2.5 to 3. These patients should also take an 81 mg aspirin daily. For the patient who's received a bioprosthetic, it's important for them to take warfarin with a targeted INR of 2 to 3 for 3 months, as well as an 81 mg aspirin daily. Nursing management for a patient with a valvulopathy primarily involves maintaining the cardiac output, improving activity tolerance, and education. There's a really good description of post-surgical management in your medical surgical textbook. Now we'll discuss a couple of additional diseases of the endocardium, starting with rheumatic endocarditis, also referred to as acute rheumatic fever. Rheumatic endocarditis is often a sequela of group A streptococcal pharyngitis. There's usually a latent period of approximately 18 days between the streptococcal infection and acute rheumatic fever. Acute rheumatic fever is an inflammatory disease involving the joints, heart, skin, and nervous system. As I mentioned, it follows an episode of group A streptococcal pharyngitis. The diagnosis is based on the Jones criteria and is divided into major and minor criteria. The major criteria includes polyarthritis, carditis, nodules often on the hands, erythema migrans, and shaking or chorea. The minor criteria includes arthralgia, prolonged PR interval, a fever, and an elevated erythrocyte sedimentation rate or C-reactive protein. In addition to the Jones criteria, cardiomegaly may be found on the chest X-ray representing carditis. Carditis can also be detected by an echocardiogram. In terms of management, penicillin is the drug of choice, but cephalosporins are used if the patient's allergic. These patients may also benefit from salicylates, corticosteroids, or digoxin for severe carditis, haloperidol for chorea, and valve replacement or repair. As you could imagine, this inflammation will extend into the valves and cause valvular damage. The last condition we'll discuss is infective endocarditis. Infective endocarditis is an infection of the endocardial surface. It may lead to valvular problems, heart failure, and myocardial abscess formation. There are a variety of etiologies, but the most common causes of infective endocarditis is IV drug abuse and prosthetic valve endocarditis. A low-grade and intermittent fever occurs in 90% of patients. A murmur occurs in 85% of patients. And you'll usually see one or more of these classic signs in 50% of patients. Petechiae, a subungual or splinter hemorrhage, which is a dark red linear lesion of the nail bed. Osler nodes, which are tender subcutaneous nodules on the distal pads of the digits. Janeway lesions, which are non-tender macula on the palms and soles. And Roth spots, which are retinal hemorrhages with small, clear centers. Here's an image showing the different signs in infective endocarditis. You may also see neurological signs in 40% of patients. These include embolic stroke, cerebral hemorrhage, or microabscesses. The patient may also be experiencing constitutional or flu-like symptoms, and you may see pallor, rales, arrhythmias, gallop, a pericardial friction rub, or a pleural effusion. Definitive diagnosis is based on 2 major criteria, or 1 major criterion and 3 minor criteria, or 5 minor criteria. Here's a table showing those criteria. The major criteria includes positive blood cultures, or evidence of endocardial involvement by echocardiography. The minor criteria includes predisposition, either with a heart condition or IV drug use, a low-grade fever, microbiologic evidence, vascular phenomena, and echocardiographic findings. The management of infective endocarditis includes the treatment of symptoms of heart failure, the provision of supplemental oxygen, empiric antibiotic therapy, which often includes vancomycin but can involve penicillins, and VTE prophylaxis.